Good evening friends, I am Dr. Chaitanya and welcome to my channel Critical Care Basics. In this channel we are running ECG lectures and this is the 36th ECG lecture on WPW syndrome and AVRT part 2. So in this lecture we are going to discuss about various arrhythmias associated with the WPW syndrome and the treatment. So let's start with part 2 of WPW syndrome. The clinical manifestations of WPW syndrome, most commonly the patient is asymptomatic when it is called the WPW pattern. The symptoms include palpitation, lightheadedness or dizziness, syncope or presyncope, chest pain and rarely sudden cardiac death. The arrhythmias in WPW can be divided into two subtypes. One is the arrhythmia requiring an accessory pathway for initiation and maintenance. So arrhythmias require the accessory pathway for the initiation and maintenance of arrhythmia. So in this we have AVRT, orthodromic and antidromic, and tachyarrhythmias which do not require the accessory pathway but they can happen in other patients also, but they happen in the patient with WPW. So they do not require accessory pathway for initiation and maintenance. For example, pre-excited non-AVRT tachycardias, atrial tachyarrhythmias, junctional tachyarrhythmias including AVNRT as ventricular tachycardia and VF. Atrioventricular reentrant tachycardia or AVRT can be seen as a narrow complex tachycardia or wide complex tachycardia. Narrow complex would be mostly orthodromic AVRT. Orthodromic AVRT means the impulse enters the ventricles through the atria via the AV node conduction system and goes back through the accessory pathway. The antegrade limb conducts the supraventricular impulse to the ventricle is the AV node, through the AV node his Purkinje system, and the impulse goes back to atria via the accessory pathway. So tachycardia is narrow complex, no delta wave on the surface ECG during the sinus rhythm as the antegrade conduction is not occurring via the accessory pathway. That is, the ventricle is not pre-excited. In wide complex AVRTs, either it could be orthodromic AVRT with aberrant conduction in the ventricles or it could be antidromic AVRT. In antidromic AVRT, the impulse passes from atria to the ventricles via the accessory pathway. So typical delta waves will be seen, pure delta waves, wide QRS complex, and it will be long RP tachycardia. So let's consider orthodromic AVRT. In orthodromic AVRT, the impulse passes through the AV node to the atria but comes back through the accessory pathway. Because the impulse passes through the normal AV node his Purkinje system, so it is a normal narrow QRS tachycardia. Delta waves are not seen. Impulse conducted retrogradely via accessory pathway. The impulse retrogradely conducts via accessory pathway to the articles, to the atria, resulting in retrograde P prime waves. This can also happen in patient with so-called concealed conduction. In patient with concealed conduction, you may not see WPW pattern when they do not have AVRT, but when they have AVRT, you will see this retrograde P wave conduction. ECG findings in orthodromic AVRT: ventricular rate ranging from 150 to 200 or greater, narrow QRX in the absence of underlying conduction system or absence of aberrancy, inverted P waves with RP interval that is usually less than 1/2 of the RR interval. So this is a short RP tachycardia. We have seen in detail in our lectures of AVNRT and supraventricular tachycardias that supraventricular tachycardias are basically divided into a long RP and short RP tachycardia. So AVNRT, which is the most common, is mostly a short RP tachycardia. Similarly, this orthodromic AVRT also is a short RP tachycardia. Lastly, constant RP interval regardless of tachycardia cycle length. So here's an example: narrow QRS tachycardia and regular tachycardia, and you see the P waves coming after the QRS complex, and see the RP interval. This is the RP interval is shorter than the PR interval. So this is short RP tachycardia. AVRT, orthodromic AVRT, is usually initiated by a atrial premature beat. During orthodromic AVRT, QRS complexes are narrow. During sinus rhythm, however, the wide and bizarre QRS complex is indicative of WPW pattern or caused by conduction over both accessory and normal pathways, resulting in a fusion beat. So see here, whenever the patient is in normal sinus rhythm, you can see a delta wave and a wide QRS complex. So this is WPW pattern. But when the patient has an atrial ectopic, he goes into a AVRT, atrioventricular reentrant tachycardia, and during AVRT there is only retrograde conduction via the accessory pathway, so you get a narrow QRS tachycardia. Since there is one-to-one retrograde activation of the atrium, a negative P wave may be present following QRS complex. Now, permanent junctional reciprocating tachycardia, PJRT. This is one subtype of AVRT. This is very rare, less than 1%. It is seen only in infants and children. It is caused by AV re-entry using AV node as an antegrade limb and slowly conducting accessory pathway near the AV node as a retrograde limb. So interval between the QRS and P prime is longer. So this is a long RP tachycardia. So as we just discussed, most of the AVRTs, orthodromic AVRTs, will be short RP tachycardia, but the exception here is long RP tachycardia. This is a rare condition in which the RP is longer because the antegrade limb is through the AV node, the retrograde limb is through the fibers around the AV node which slowly conduct the impulse. This is a congenital condition. So this is a differential diagnosis of long RP tachycardias. Now, antidromic AVRT. In this, the impulse comes from the atria through the accessory pathway. Because it comes through the accessory pathway, the QRS will be wide and the pure delta wave will be seen, and impulse goes back through the AV conduction system. Antegrade conduction through the bundle of Kent and retrograde through the AV pathway. Anomalous ventricular activation, pure delta waves is seen, and this is rare. The ECG findings: ventricular rate ranging from 150 to 250 or greater, inverted P waves with RP interval that is usually more than 1/2. So this is a long RP tachycardia, wide QRS due to the delta waves and long RP tachycardia. Wide QRS complexes which are fully pre-excited, typical pure delta waves, constant RP interval regardless of the tachycardia cycle length, and this can be initiated by an atrial premature beat or a ventricular premature beat. So this is antidromic AVRT. You can see typical delta waves, wide QRS complex, and the P waves coming quite late. In this you cannot differentiate the P waves, but they are coming later, or the RP interval is longer. Now, atrial fibrillation in patients with WPW syndrome. Atrial fibrillation occurs in 10 to 30% of patients with WPW syndrome. Usually it originates within the atria or pulmonary veins independent of the accessory pathway, but sometimes accessory pathway itself may lead to atrial fibrillation. The rhythm, naturally atrial fibrillation, the rhythm will be irregular with QRS morphology changes from beat to beat, which can be associated with rapid AV conduction. Sustained ventricular rate greater than 180 to 200 per minute can create a regularized RR intervals. So the ventricular rate is so fast, so you may think that is a regular ventricular tachycardia, something like that, when ECG is recorded at a normal speed of 25 mm per second. And when atrial impulses are transmitted along the accessory pathway in AF, ventricular rates may exceed 300 and it can rapidly degenerate into ventricular fibrillation and death. So these are dangerous. So whenever atrial fibrillation occurs in patient with WPW, it may take one of the three routes. Conduction through the anomalous pathway only. This is most common. Activation of ventricle essentially through the anomalous pathway. The pure delta wave will be seen, completely bizarre QRS complex. No impedance in accessory pathway, so ventricular rates are much faster, and this is dangerous. Ventricular response in the region of 182 to 200 beats per minute, and sometimes even up to 300 beats per minute. This can rapidly degenerate into VT or VF. See the wide QRS, dangerous looking tachycardia. So irregular rhythm points towards the AF, and in this WPW syndrome, it's a relative emergency, medical emergency, and importantly, you do not give AV nodal blocking agents in this. Antegrade conduction through the normal AV nodal pathway, this is rare, occurs infrequently, sporadically, usually for 1 beat only, normal QRS complex. So this is WPW pattern, and when the patients develop AF, the impulse passes through the normal AV conduction system, and you can see normal QRS complex. And lastly, antegrade conduction through both pathways. So sometimes the antegrade conduction is through the accessory pathway giving the wide QRS complex, and sometimes it is through the normal AV conduction system giving rise to a narrow QRS complex, and sometimes there is a fusion. So typical fusion complex of WPW. So this is an ECG of a patient with WPW syndrome and atrial fibrillation. The conduction is through the anomalous pathway. So you can see wide complex tachycardia and irregular rhythm and beat to beat variation in the shape. So this is a dangerous ECG. Such patients can land up in ventricular fibrillation, deteriorate into ventricular fibrillation. So this patient was given immediate cardioversion, and see the patient has come in a sinus rhythm. You can see P waves here. Now this is the approach to risk stratification of asymptomatic patients with WPW pattern. So you may come across patients who have WPW pattern in their ECGs. Now what do we do about it? Is it dangerous? Do we send them for ablation, or do we just neglect? So this will flow chart will throw some idea, give us some idea as to how to approach such patients. Is the pre-excitation permanent or intermittent? If it is intermittent, then it becomes a low risk category. So no treatment or medical treatment. Persistent. If the ECG pre-excitation is persistent in the ECG, so there is a possibility of high risk for sudden cardiac death. Perform non-invasive evaluation including exercise ECG. So get a TMT done. During TMT, is it intermittent WPW or persistent? If it is intermittent, again low risk for sudden cardiac death. So routine outpatient follow-up in cardiology. If it is persistent, then during the TMT, see for red flags. Multiple accessory pathway, perform invasive testing with EPS. So if it is persistent, perform EPS, and the red flags during EPS are multiple accessory pathways, inducible AVRT or AF during EPS, shortest RR interval less than 250 milliseconds, and accessory pathway refractory period less than 240 milliseconds. If the answer is yes, then it is high risk, the patient is high risk for sudden cardiac death, and you go ahead with ablation of the tracts. If the answer is no, then you can continue in medical management or routine cardiology follow-up. Now suppose a patient with AVRT comes to you. How will you know that the patient has AVRT? Most of the time you will not know. What you will see will be a narrow complex regular tachycardia, and it will be mostly a short RP tachycardia. So short RP, narrow complex, supraventricular tachycardia, maybe AVNRT or AVRT. Suppose it is AVRT, and if the patient is hemodynamically unstable, the treatment is synchronized cardioversion. If the patient is hemodynamically stable, the treatment will be similar to all the AVRTs, all the supraventricular tachycardias. First line will be vagal maneuvers, second line will be IV adenosine, and third line will be IV non-dihydropyridine calcium channel blockers like verapamil or deuterazine. If the patient does not respond, then you may try procainamide or again synchronized cardioversion. During the chronic prevention phase, once the acute tachycardia is controlled, for chronic prevention, the best would be catheter ablation. Second line would be oral flecainide or propafenone. Third line will be class 1A antiarrhythmic or amiodarone. For antidromic AVRT, wide QRS, typical pure delta waves, and usually a long RP tachycardia. Such will be the ECG picture of antidromic AVRT. For acute termination in unstable patient, again synchronized cardioversion. For stable patient, IV procainamide. Synchronized cardioversion if procainamide is not available. Importantly, adenosine, verapamil, diltiazem, beta blockers and digoxin are contraindicated. Chronic prevention, again first line is ablation, second line is oral flecainide or propafenone in absence of structural heart disease, and third line will be class 1A antiarrhythmic or amiodarone. The treatment of pre-excited atrial fibrillation. Patient has WPW with AF. So the treatment option, if the patient is unstable, synchronized cardioversion. And naturally, all the drugs which reduce the AV conduction are contraindicated. For stable patient, first line is IV ibutylide or IV procainamide. Others, you may try class 1C antiarrhythmic drugs or dofetilide. For chronic prevention, again first line is catheter ablation of the accessory pathway. Second line is oral flecainide or propafenone, provided the patient does not have a structural heart disease. Or third line, class 1A antiarrhythmic or class 3 antiarrhythmic like amiodarone. Importantly, digoxin is contraindicated. So that was the treatment of AVRT and the WPW syndrome. If you are liking these lectures, please like, subscribe and share.